Hi, my name is Pierina Brando, and I'm going to talk about Gigantism and Acromegaly due to Xq26, Microduplication, and GPR101 mutation. Definition. The somatic growth involves the hypothalamus, pituitary, and peripheral tissues. Genetic disorders that affect this network can lead to increased secretion of growth hormone, which results in acromegaly. If the excess in growth hormone occurs before epiphyseal fusion, the results can be gigantism. Non-syndromic gigantism is most frequently caused by pituitary adenomas occurring as familial isolated pituitary adenomas or sporadically, usually as a result of mutations in the gene encoding early hydrocarbon receptor, interactive protein, AIP.
Manifestation of excessive growth hormone, or GH. The growth hormone is produced by the anterior pituitary gland. The most common cause of unregulated growth hormone is a pituitary adenoma, so a hormone secreting tumor of that pituitary gland. And this adenoma might be microscopic, so small that you can't see it on a scan, or it can be significantly sized so that it causes compression of the local structures. Rarely, acromegaly can also be secondary to a cancer, like a lung or a pancreatic cancer, that secretes either ectopic growth hormone releasing hormone, or GHRH, or ectopic growth hormone itself. There's a structure called the optic chiasm, and this sits just above the pituitary gland. And what this optic chiasm is the point where the optic nerves coming from the eyes cross over to different sides of the head and enter into the occipital lobe, which interprets those visual signals. And a pituitary tumor that has significant size will start to press on this structure called the optic chiasm. And pressure on the optic chiasm will lead to a stereotypical bitemporal hemianopia visual field defect. So what this is basically a loss of vision of both the outer halves of the eyes, because as the visual signals from the optic nerve come through the optic chiasm, the signals that sense the outer part of the visual field cross over in the middle, and it's this middle part that is pressed on by the tumor. This causes loss of vision of the outer sides of the eyes, which we call bitemporal hemianopia.
Applications in medicine. A striking phenotype of gigantism that has an onset in early childhood and there is caused by an excess of growth hormone. The disorder is associated with heritable microduplication on chromosome Xq26. There are 4 genes in the duplicated stretch of DNA. One of these, GPR101, encodes an orphan G protein, coupled receptor, and is probably the gene that drives the phenotype in young children and the growth of sporadic growth hormone, producing adenomas in some patients with acromegaly.
Growth factor 1. IGF-1 is what causes your bones and other tissues to grow. Too much growth hormone leads to too much IGF-1, which can cause acromegaly signs, symptoms, and complications. Symptoms of acromegaly, which can take years before they are recognized, include growth of the bones of the hands, feet, and lower jaw, and protrusion of the size of organs, and excessive sweating. The diagnosis of acromegaly can be made when there are elevated levels of insulin-like growth factor 1 and growth hormone. An MRI can help confirm the presence of the pituitary tumor. Treatment of acromegaly depends on the underlying cause. If there's a pituitary adenoma, then surgery can be done to try to remove the growth. And in cases where that doesn't work, radiation therapy can be used. Medications like somatostatin analogs can also be used to inhibit the growth hormone production. Alternatively, growth hormone receptor antagonists can be used to stop growth hormone from binding to target tissues.
Pros and cons. Pros. The genes Xq26 microduplications can be considered to be a new pathogenic explanation in certain kindreds with familial isolated pituitary adenomas that have acrogigantism without IAP mutation. Several lines of evidence support the identification of a new pituitary gigantism syndrome in young children carrying microduplication on chromosome Xq26, a disorder that is probably caused by the GPR101 overexpression. Cons. In all the patients, hormonal control was not achieved with medical therapy alone. Such control required either radical or repeat neurosurgery alone, or in combinations with administration of the growth hormone receptor antagonist, prednisone, or radiotherapy.
So first, by using standard XGH, found mutations from Xq26 and observed mutations in 9 patients like sporadic mutations and also independent. And recently, we also found other mutations like gigantism and and look at the boundaries of this mutation, that there are two regions that are shared by and these regions are called the smallest regions of overlap or SROs. And in particular, you can see here SRO1 and SRO2, and these two regions contain 4 proteins. So with the help of Xq get data, we then refine our analysis by using high density. On the left here, you can see some examples. So the red arrows represent and under the you can see the cyber sequencing of breakpoints. And as you can see, these are caused by a very short sequences. Sometimes the sequences where one of the sequences will be or small insertions. And on the right, you can see a schematic drawing explaining
Issue applied in Ecuador. Acromegaly predominates in females and is diagnosed in the fourth decade with a delay of approximately 8 years, usually even longer in males. Incidence and prevalence are lower than reported in international series. The disease is underdiagnosed and underreported in Ecuador. Conclusion. In conclusion, Xq26 microduplication is associated with a clinical syndrome of early onset gigantism, which we have termed X-lag. An increased dose of GPR101 on chromosome Xq26 probably causes the disease, and its activation by mutation occurs in patients with sporadic acromegaly. Xq26 microduplications may explain other historical cases of gigantism and features that closely resemble those of X-lag. Thank you.